Hi, everyone, and welcome to ABC's of Anesthesia. Now, today we've got a bit of an interesting episode because I've got with me Luca. So, Luca was a mechanical engineer, and then he made that amazing transition to be, I guess, a medical student in future a doctor. But he's a first-year medical student at Deakin University, and he approached me because he has an interest in anesthesia, especially pharmacology from way back, and he just wanted to help out and see what he could do with as an ABC's of Anesthesia volunteer. And the first thing he said was really to uh, ask a whole bunch of questions which we haven't actually covered in ABCs of Anesthesia that's really relevant to anyone thinking of a career in anesthesia. And the first thing that's interesting, Luca, first of all, welcome. Thanks so much for approaching me.
Thank you. Thank you. No worries. Thanks for having me on. I appreciate it a lot. It's good to be
and
here.
and it's great that you're a first year medical student. And most times, medical students do definitely approach me, but generally it's going to be interns and residents and registrars who want to help out. But even as a medical student, like this is exactly where you're at the exact right level to be pitching these questions because it's of interest to you. So it's great that even as a first year medical student, you can really be contributing to any project really because you're seeing it from a completely different lens, but it's useful to a whole group of people.
Yeah. Let's hope I represent the anesthetics interested medical students well here.
Yeah, absolutely. So I guess this talk about, essentially, I think you can ask me lots and lots of questions about what life is like as an anaesthetist. And yeah, I'll try to give people just a really honest insight about, what it's like. So a bit of background from my practice. So I'm in Melbourne, Australia. I work full-time in a public hospital, which is like 4 days a week, which is, roughly 10 hours a day, 40 hours a week. And I do a bit of private, so that's the rest of the time is made up by doing, working in a small private hospital that does cataract operations, where I do everything from topical anesthesia to regional eye blocks and occasionally general anesthesia. So that's kind of the makeup, and then the rest of the time, whatever other hours I have in the day, I run the Anesthesia Collective and ABCs of Anesthesia. So it's a completely full plate, and try to see my friends when I can. Yeah.
Sounds like there might not be too often you've got a lot on your plate, obviously.
It's not so bad. Yeah, let's get started, Luca. Go ahead and ask me whatever you want. Ask me anything.
All right, let's go. So I think the first thing is one major reason why people seem to be interested in anesthetics is that it's a so-called lifestyle specialty. It's sort of listed in one of the road specialties, namely being the A one. So I just want to ask you, road is it's radiology, ophthalmology, anesthetics, and dermatology.
Yeah.
And so I just wanted to ask you, as an anesthetic consultant, both with private and public experience, would you describe it as a lifestyle specialty in Australia?
Yeah. So I think the phrase lifestyle specialty is pretty much the whatever gives you the options of doing whatever you want to do. So, for example, if you wanted to work 7 days a week in anesthesia, you could absolutely work 7 days a week in anesthesia. You could work so many hours. But the thing is that because you are contracted and requested, say, by a surgeon to work, or you work in a public hospital with a certain amount of time, you can opt to work the hours you want to work, for example. So like if you're a surgeon and you do an operation, you kind of have to stay for that operation. You can't really hand it over because there's a certain uniqueness to your operating ability. So in public, most surgeons would stay for the whole case, whereas the anesthesia can easily be transferred. So for example, from a lifestyle point of view, if I'm on a long case, often we have these livers or big hepatobiliary cases. If it goes past 6 o'clock, if I really can't stay, and they have someone who can take over from me, I'll absolutely hand over that case. Whereas the surgeon will potentially work on that case for the whole 10 hours, 12 hours, 16 hours. Occasionally I've been in cases working cases for over 24 hours. There's really, really long transplant cases. And yeah, the surgeons take breaks, but they are there for the whole time. Whereas generally, you can swap in. With the private work, it's interesting because you will absolutely have to be there for the whole case as a private anesthetist, but you can always take time off without too much detriment to your practice. For example, a surgeon has patients, and the patients rely on the follow-up and the repeat appointments and everything. Whereas as an anesthetist, the patients, I don't own them. So again, I can have someone subbed in for me, and I can go on leave and someone can come in and do the anesthetic for me in that next week. Not having my own patient cohort means everything for the lifestyle nature of it. And then, most specialists in Australia are just paid really well. So, if you didn't really care about your income too much, you could have a really comfortable life, working 2 days a week, if that's what you wanted. I think what most people do is they try to balance family and other obligations. So I think most anesthetists probably work 3 to 5 days a week. That's probably the kind of the balance. And if you have kids, you might drop down to a couple of days a week, or 1 day a week, or no days a week, and then increase it as things change.
Yeah, okay, that's a really good point. I mean, I did kind of know that you could switch in and out, although I didn't realize that in my mind, it was always they're switching out to have a break for a while and then come back. So it's good to know that there's also that option of sort of switching out so that you can then go home and the other person takes over permanently for the rest of the case or whatever.
And the subtlety of it, like say my eye surgeon I work with, he runs this really fantastic clinic, and I think he told me the outgoings are 30,000 a month just to keep the clinic going, all the employees and all the other amenities and everything. So when he's going to take some leave for a few months, and he's got to get a replacement for that time, and he's not making any income, and he's paying $30,000 a month just to keep the place running. So it's a formula that you can't do as a surgeon easily, whereas you can do as an anaesthetist, because you're not paying rooms to you don't have to pay exorbitant fees for rooms.
Yeah, no, that's a very good point. And I think something I do think I know about sort of some of the subspec surgical specialties is that, there's so few of the specialists that if you aren't doing something, then realistically you need to organize with them to be able to do it. Whereas anesthetics doesn't have that problem so much.
Yeah. And here's the thing, actually, you could probably make any medical job a lifestyle specialty, because you fulfill these criteria. Now I'm riffing here, but you get paid well, so you don't have to work a full-time job to make an adequate salary, that like an average Australian salary, and you just have to choose to work when you work, not worrying too much about your progress or career. For example, you could locum as a general surgeon. So again, the hospital will own the patients, and you don't mind that you work a couple of days, and you come in as a bit of a hired gun, so to speak, for those operations of the day, and then you leave. And one of my opthal mates, he definitely does that. He just does locums. He hasn't really built up his own practice, but that allows him to do his other entrepreneurial things.
Cool. Yeah, that's awesome. I wasn't really aware of that, but it's good to know.
Yeah.
So just following on from that, so you're basically saying, yes, it is depending on how you do it yourself. It's just the flexibility that mainly lets you do that. Are there any aspects of the job that you would say are much less lifestyle leaning than people would expect?
Yeah. So I think if you end up working in a department and then you have responsibilities, like you're part of the executive team, the director, the supervisor of training, unless you have the right level or the numbers of people to help support that, then you probably are more tied to your role. Like I have so many roles in my public hospital, and most of them I absolutely, so I love the roles. And even when I go on leave, I will be troubleshooting those roles the whole time. And it's not too much of a barrier to me. Like, I don't care replying an email when I never have I'm on leave message, because I'll always be available for the, just putting out the fires as I need them. But yeah, the more responsibilities you have from an administrative point of view, it becomes less lifestyle leaning. And also, if you're part of some kind of transplant team or cardiac team, you're on call at certain times, which makes the on-calls are probably a bit more strenuous if you're a cardiac or transplant anaesthetist, versus someone else. I'll have on-calls in my hospital, but first of all, I can often give them away to other people who want the on-calls because they're well remunerated. Whereas other places that have a rostered and a salaried position, it's probably harder to give away the on-calls. So it's the subtlety of the hospital you work at. If the on-calls are part of your salary, harder to give away. But if they're paid per case, like in my hospital, it's probably a bit easier to give away those on-calls.
Yeah. Okay. Awesome. It's good to know. I didn't actually know that's how that works, but
yeah. Neither did
I. Okay, so just continuing this sort of line of thinking, how does the lifestyle of an anesthetic trainee compare to that of a fellow specialist?
Yeah, I think there's two major things. Anesthetic training is a time of just rapid learning and lots of discomfort. as well as lots of rewards. But it's a massive growth phase. You're getting more and more responsibility. You're doing more and more things by yourself, and by its nature, anesthesia is most of medicine's a high stakes game, but anesthesia especially, because when you give that muscle relaxant, if you don't ventilate the patient, the time to death is very short. In the 5 minutes, 3 minutes kind of realm. So it's high stakes. So you're learning, and you're sitting these incredibly difficult exams where you're studying for usually 12 months, each of those, and having to, do your volume of practice, doing it after hours, learning all the different things to work by yourself, learning, all the different training courses. So that is incredibly rewarding. And I loved that time, even the exams. I mean, they were tough exams, but, when I think back, I'm so glad that I did those, because, I wouldn't want to be at the end of something that wasn't, super difficult to get to, that not anyone can do what we do. So that, I think that was extremely rewarding. The flip side of that is, as a consultant, you don't have any exams unless you choose to do further learning, which is great. But then you have this incredible amount of responsibility. The buck stops with you in many, many cases. But because you're so highly trained, it's great being autonomous. No one really tells me what to do. I'm my own practitioner. I make sure that I work within the right regulations and guidance and protocols, but no one's really micromanaging me. So like lots of responsibility, but you're not being micromanaged. You're totally autonomous. Whereas as a registrar training, people are always telling you what to do, and often it's opinion based, not absolute fact of what you need to do.
Yeah.
You can choose to probably have less on calls as a consultant. So yeah, and you can choose to decrease your hours, whereas a registrar, you will almost always do 43 hours a week, kind of the 86 hours a fortnight type mix.
Yeah, it's sorry. It's interesting that you look back on your registrar days with quite a bit of fondness, it seems. Because to be honest, when I see registrars talking about their life on Reddit or wherever else, it's usually a lot less jovial than how you were just describing it.
Yeah. Oh yeah, there's definitely, it's that, no matter which kind of doctor you are, when you're working in that hospital and doing a night shift, you're so tired and exhausted, because you're on night shift. And I remember working 9 nights straight once, and I just started reverse cycling. Like, I was just completely awake. I was a vampire. Like, I could just stay awake. It was no problem. I slept the whole day.
Yeah.
And I was trying to swap days so I can get to an interview, and it was, it's a really weird time to be on night shifts. And that moment when you get woken up, whether it's for an admission or some deteriorating patient, or in anesthesia is often trauma calls, pain calls, epidurals. When you're at that point of really deep sleep, it's like, say you are sleeping overnight, because you're in a smaller hospital, you're called up 3 a.m. Every part of you just does not want to get up, but it's just professionalism. You just have to get up there. I remember it was a bit disgusting, but I'd just take a shot of coffee just to snap myself into gear as a resident. So not and just okay, I can get to it now.
Yeah. Just need something to kickstart the body a little bit, I think.
Yeah, exactly.
Alrighty, so moving on to sort of the next line of thinking. What for you made you go, yeah, anesthetics is what I want to do?
Yeah, it's a really interesting question, because I tell a lot of medical students this, that you will probably choose your career based on bad evidence. For example, most of the time, I'm not sure how the culture has changed. Like, I think the culture at my hospital is far nicer than it was at my training hospital years ago. So it could be a time thing, it could be a culture thing. But I think people think they see what they see and like it. So you might see what your registrar is doing in a public hospital setting and think, oh yeah, that looks good, and that's what I want to do. Whereas the majority of your career is as a consultant in a potentially another setting, like a private hospital or small hospital. So first of all, you don't really know what the world is like. So when I went into anesthetics, it's on the back of doing lots of rotations where, I think I worked really hard. I think I did a pretty good job, but the culture was that if you do everything right and go above and beyond to do everything right, that's not a commendable thing. That's your job. You just have to go. Whereas if you do something wrong, you miss something, and there's always way more tasks than you have time for in a day, which is just really unfortunate. You pretty much just get told you need to time manage better. and you just prioritize, and you kind of get this broken record of, oh, you just got to learn how to be efficient and prioritize. I'm like, look, if you've seen my task list, I don't know if anyone could do this in the time that I've been given.
Yeah.
So anyway, we're going to anesthetics. Suddenly people were pleased by the simple things that I did. I put a drip in, and I was pretty good at drips even as an intern, and never really called anyone for help. And I could get them in, and the consultants were really impressed. And I just turned up early and would see my patients and make a plan and, show a lot of effort. And again, they would praise me. And for some reason, anesthetics consultants were happy with me and were willing to praise and say, you're doing a good job. Whereas other consultants, either hadn't seen me or the registrars weren't as forthcoming with the praise. So I thought, hey, maybe I'm meant for anesthetics. Whereas I was probably just in a zone where, in a profession where people were just, more relaxed and just more reasonable about telling you you've done a good job or not.
Yeah, no, that's awesome. That completely aligns as well for me with what I've heard about anaesthetists in general. It seems like there's a really high quality of like character in the specialty, which is nice to have that like not reciprocated, but like confirmed where you're here.
Yeah. And so what you're doing now, asking me these questions of life as a consultant and comparing it, that's exactly what everyone should probably do for every specialty that they're interested in. I'm sure you can just go on YouTube and go day in the life of, and get the whole spectrum of everyone and what they're doing. So
yeah, for sure. Alrighty. What's one positive thing you were surprised by once you entered anesthetics, either as a registrar or a consultant?
Yeah, so definitely as a registrar, going from medical and surgical jobs where you're just on your feet, just absolutely chasing your tail the whole time. With anesthetics, you get breaks. You've got one-on-one time with a consultant, and you feel really odd because after maybe a couple of hours of work, they go, oh, hey, have a break, come back in 20 minutes. And that's not something that's ever encouraged. Or it's almost like after being offered so many breaks, you almost feel like, do they even want me there? It's just the culture. You don't need to be there when you're a junior, and they probably don't want to be teaching you the whole time. And it's not important that you're here for every single second. It's just go. So breaks were great. I was surprised that most anesthetists seemed really, well balanced. Like they had lots of interest. They would talk about lots of other things in life, whatever the restaurants, the place that they travel to, the kind of fitness and whatever their cycle was, but they all have expensive bikes, and they seem to be really into triathlons or whatever it is. And so that was interesting because from the other side, there's lots of doctors that are very into good health, but it just seemed like it was more prevalent in anesthesia. And then as a consultant, I was just really pleased. I didn't really think that I wouldn't need to do as much on call. I didn't really register. So as a registrar, I was like, oh, I'll be doing night shifts for the rest of my life. And I was actually pretty happy with that. But as a consultant, I really don't need to do on call, but I do because it's good for you. You stay sharp with the toughest cases, the emergencies that come in overnight. And I think that keeps you on your toes. But you never want to just get lulled into the same old without being, pushed out of your comfort zone a bit.
Yeah, that makes sense. And it's funny you mentioned the most were fit thing, but in that you also sort of spoke about how anesthetists tend to have a lot of varied interests. And that's funny because I spoke to an anaesthetist on Reddit once, and he was saying, like, I told him about one of my interests, which is a little bit esoteric. And he was saying one of his favorite parts about being an anaesthetist is that so many anesthetists have really varied and very like sort of random but interesting interests.
Yeah.
So yeah, that's awesome. So on the other side of the coin, I was curious, like what's a negative thing you were surprised by once you entered, again, either as a registrar or a consultant?
Yeah. Maybe one of the negative things is that there are so many consultants with so many different opinions on how to do something. And just know that once you get outside of become a consultant, understand what's going on, people agree about most of the things, whether you're in anesthetics or surgery, everything that everyone's doing, everyone's already agreed on. And it's just that fine tuning at the kind of the edge of what, science and evidence hasn't really confirmed for us. So, but every consultant might tell you this is the right way of doing things. And you get really confused in those first couple of years about what exactly is the right way of doing things, because most of the time I was told almost contradictory between consultants that this is the only way of doing something. It's part of what made me want to start off with my ABCs of Anesthesia bootcamp series, just to give people a really reasonable pro forma on how to go step by step from the start of an anesthetic to the end of an anesthetic, so that they could then use that as a framework or blueprint, and then vary from that. But it's so confusing when you start off because there's just so many variables. And again, like if you think about the induction space, you're supervised by a consultant one-on-one. You've got to do probably 50 different tasks and more maneuvers of your hands and movements and thoughts. And those happen in the space of a couple of minutes, maybe 5 minutes max. So that's really hard to learn without just doing lots and lots of repetitions.
Yeah.
Yeah.
Yeah, no, that definitely makes sense. And yeah, I've even witnessed that, well, felt that a bit just from reading things. I'm just like, okay, well, I saw one person say, no, this is the way. And then, yeah, someone else says the opposite. So I definitely see how that can be confusing.
Oh, yeah. And I remember reading, I think it's some American book about pediatric anesthesia before I was starting pediatrics, and none of it was practical. I was like, back then, there was not really a good pediatric resource. And there weren't a lot of just real basic anesthetic books as well. Like the Oxford Handbook, I found absolutely useless. it wasn't, I don't know what it was. It just didn't give the right information I wanted. Again, the reason why I set up ABCs of Anesthesia, so that if I, if I do this, and this, and this is going to work.
Yeah. Yeah. And I think sometimes things also might, resources might go into too much detail about some, physiological mechanism or something. It's like, okay, but how does this translate into what I do in real life?
Yeah.
And that can probably be difficult.
Yeah, absolutely.
Alrighty. How have you seen anesthetics change over your medical career, both positively and negatively?
Yeah, I'm actually trying to think if there isn't. Definitely the positive stuff is the technology that we have now. So for example, when I started, video laryngoscopes were probably just being introduced. So this was starting training in 2008, so 2008, 2009. And you kind of had to have a bit of a license to practice. Like you need someone supervised to use a video laryngoscope, whereas now it's like just say you work in any hospital, definitely outside of theatre, they just give you a video laryngoscope because that's got higher first pass success rates. So video laryngoscopy has been a game changer, where previously, I literally in the last week, I had a patient who brought a letter in saying they were a difficult intubation, and this letter was from 1998, and it said this patient has a grade 3 airway, recommended a weight fiber optic if you are going to do a rapid sync induction where you may not want to ventilate the patient. From my point of view, a bit of old school thinking. But when I saw that letter, I was like, oh, this is not a problem. If I've got a video laryngoscope, so I went in and try to see what my direct view was, and he was like, yep, this is a genuine grade 3. This would not be an easy airway for someone to manage, even a consultant to manage. Like if I didn't have a video laryngoscope, I'd just put the bougie and get it around the corner, or get a fiber optic out, but be able to bag mask the patient, and it'll be safe enough, but hard to intubate. But then because I know I've got video laryngoscope, I'm like, well, this is not even a problem. I'll just get a video laryngoscope and make sure I get a flexible chip bougie or a hyperangulated blade with a stilette to just pass it through. And the video laryngoscope indirect view was amazing. It was like pretty much 100% of the glottic opening on view. So that change of video laryngoscopy has been an absolute game changer for airways. It's probably, if you didn't learn with the normal technique, you probably miss out something on optimizing technique from what I've seen. Like you don't have to have your technique as good with a video laryngoscope. But again, that's just evolution of equipment. The example I have is ultrasound, portable ultrasound became commonplace, and there was funding from the government to have it in most of these hospitals in Victoria, I think. So suddenly I could learn regional anesthesia without, in my hospital, we didn't do too much, so there weren't too many kind of regional experts. And the nerve stimulator technique, a lot harder to learn, landmarks and knowing exactly what you're looking for, and a lot of variability. So I could learn ultrasound guided regional anesthesia, I wouldn't say by myself, but very self-directed, without needing a lot of expertise. I just needed a couple of people who could answer questions, and I could learn that, just because ultrasound was now absolutely prevalent. So I will never really learn the nerve stimulator technique, and it could become a lost art once the generation that had that retire and don't teach it anymore. And again, there's no reason for me to learn it because I've always got an ultrasound scan around. With the ultrasound being portable, there's also echo ability. You don't need the big machine that the sonographers use, the cardiologists use. We just have this portable ultrasound. It's so useful for vascular access and echo. And again, anyone who's studying anesthetics, that's definitely a skill that you want to learn. Probably the final thing that I've seen change, this isn't neither positive nor negative, and maybe a bit contentious, is that people are really pro TIVA, and there's probably some good environmental reasons and nausea vomiting reasons, and maybe some level of people talk about emerging evidence for maybe it's beneficial for cancer operations, but emerging evidence probably just means that there isn't evidence, but people hope there will be evidence. So I don't really, yeah, it's not there yet, and maybe people will find that it'll make a difference, maybe not. But yeah, lots of TIVA, so total intravenous anesthesia with propofol, is being used more than I ever thought. Like that's now seems to be the default in my hospital, whereas I still, as a default, use volatile and then use total intravenous anesthesia for specific patients.
Yeah, and I mean, like you say, at the point where we're still figuring out the science, it does sort of allow for anesthetic to be a bit of an art as well, I think.
Yes.
Which is kind of a cool part of it. So probably leading on from that a little bit, what are you excited for in anesthetics for the next 20 years?
Yeah, I mean, from my personal point of view, like I'm really excited about what education can become, and I will do everything I can to make education in the anesthesia realm, especially in the like there's this whole spectrum of the beginner level, intermediate level, advanced level of training, and I'd love to be a big part of that. And again, I think the flexibility I have is that I can just go and do it. I don't really need any approvals from any bodies to try stuff with education. Whereas it's a bit hard if you're in a big institution. So being nimble and quick and having resources and lots of talented people working with me helps me to do that. So I'm really excited to see what that can do. And I think there's something else. I mean, I think people are potentially very threatened by change. So there's definitely automation, like autopilot settings with anesthetic delivery of agents. And that's, I think it's even a few years ago, they already had these models. It hadn't rolled out yet, but it could mean that, there's some level of, not needing an anaesthetist for the whole time of the operation. So that could be a threat to our profession. Same with AI, whatever AI can do in terms of, patient preoperative and postoperative assessment and care, that could be an absolute threat, just like it is for algorithms for diagnosis in ED or algorithms for reading chest x-rays. All of these can absolutely be a threat to us, to any specialty. But I think the biggest thing is that just not to be afraid of it. Like, if you were a cab driver as Uber was coming in, and you didn't see that and didn't really lean into it and try to learn more about it and try to risk manage your situation, whether it's that or anything else. Like think about all the major changes that happen. If you were in the TV space and didn't think YouTube was going to be a big thing, then what are you doing? You're just with your blinkers on. So I think I hope that I'm able to just lean into it. If someone invents something that's going to replace me, I'd like to think that I'd want to back that thing in a way. Like I'd maybe want to invest in it so that I'm investing in the thing that replaces me, so that I will still have an income potentially. I say that not really knowing what that looks like, so I don't have too much. But if there's something that's a threat, don't be afraid of the threat. I think lean into it and see what that sort of supposed threat is, because you may be a good contributor to that in the future. Like many countries in the world have nurse anesthetists who are very well trained. They do have a very specific skill set for certain operations. But the reality is a lot of things can be done by people less trained, whether it's surgery or being a lawyer or being an accountant. Lots of parts of everyone's job is replaceable. And there's a good ethical argument for, is medicine too expensive? Like, do we have to make it more affordable for everyone, and not just from an Australia point of view, but worldwide point of view? And I think, I really believe in that, equality of access to things. So part of me would be threatened, but the other part of me would think, as long as it's truly beneficial for the rest of the world, and I'm not against things like that.
Yeah, no, that makes sense. And yeah, I do agree that with technological change, it's often going to happen whether you like it or not. So it's best to try to get to do it the best way you can.
Yeah.
So on the flip side, what are you worried about with anesthetics, like for the next 20 years or so?
Yeah, I mean, that's definitely a worry. But because I'm kind of 10 years into my career, there's probably not many things that are going to change too much, and I'll probably have, always have some level of work no matter what the change happens. But if you're starting out, it could be a bit of a tricky thing. Um, but yeah, like definitely, I would hate if the standards dropped for anesthesia. Like if there's some things that I think are probably a little bit unnecessary, like such a difficult primary exam is probably a bit unnecessary from my opinion. But I think things like the final exam should probably be more objective and harder. And standards shouldn't be lowered too much. I think we have a lot of brilliant people, and if we just get the education right and just the systems of testing that correct with really good workplace-based assessments and trainers and everything, I think we can keep the standards really high without having so much money invested in overly complex systems and exams. And that's definitely something to think about for the future. But yeah, I would hate if the expertise of the anaesthetist was lowered.
Yeah, no, that makes total sense, especially in a specialty that, like you said earlier, so it's such an acute sort of where things can go wrong really quickly. You want to have the best you can.
Yeah, absolutely.
So I mean, we've already talked about this a little bit. I'm about to say, because I mean, you've spoken about automation, AI, and things. But is there any emerging anesthesia-related tech you're excited for? So, like, I think one thing I've seen people talking about before is like end-tidal propofol type monitoring and stuff as well.
Yeah, that would be absolutely exciting, because that would be a game changer for me. The fact that I might have a patient with the arms tucked in and I can't see the drip, so I don't actually know what's actually in the vein. That's a big deal for me when I run TIVA. Especially if there's no strong indication for it. It means that even if there's a 1 in 1,000, 10,000 risk of awareness, that's I could have used volatile and not had that risk for the patient. So that, from my point of view, I don't really want to subject people to that. I think the other things that I'd be really excited about would be I went to this conference in Glasgow, and someone had a pain monitor, so you could they just had a sensor on your hand or arm, and depending on how much neurotransmitter was released at a certain time. And literally, this PhD scientist pinched my skin and showed that the waveform went up. So not really a test. And I was a bit disappointed, because I asked her, "Hey, can you show me your papers? Just send me your papers. This is really interesting to me." And she didn't have any randomized control trials or any kind of evidence to send me. She just had some kind of product information documents. I'm like, you're a PhD postdoc professor of your area. Surely you would know what evidence is and what I need. And she just didn't follow up on that. So I was in spite of an email thread, I was like, well, maybe it's not quite there yet, but if it does happen to be there, real-time monitoring of pain would be an absolute game changer. Real-time monitoring anything, HB, blood gas results, would be an absolute game changer. And even like automated cannulations and things to make it easier for the very difficult cannulas. Like, I think there's an automated epidural insertion kit that has this contraption, and it can find loss of resistance on its own. I suspect that we're probably far away from an IV cannulation type system, but there might be something out there soon.
Yeah, no, that's awesome. Yeah, the pain. Yeah, I totally see anything real time would be amazing. Just helps you solve so many problems before they become actual problems. Okay, this one's perhaps a little bit different. What's the biggest mistake you think junior doctors make when selecting anesthetics as their specialty?
Yeah, I mean, I think if you choose anesthetics, you got to know what the world is like. It's like if you have trouble learning, like some level of disadvantage learning, which is unlikely if you've done medical school and done those exams. But the anesthesia primary exam is this just absolute beast of an exam, and it covers so many. You have to have the mental bandwidth and space and life, circumstance to be able to do it. But also, there's some really intricate mathematics and electrics, and understanding physiological principles. So you have to have a level of interest in some of these things. People still get through it without having a really good grasp of mathematics. So I don't think it's too much of a deal breaker if you're not great at maths and physics and chemistry. But I think it probably really helps if you are able to do that. I think most of medicine these days is a lot about emotional intelligence and memory and learning, having a really good work ethic rather than IQ per se. But yeah, I don't. Besides that, I don't think there's too much of a big mistake. I think people. I used to fear this fact of being so responsible for someone. Whether you're a surgeon or any other doctor, like you really have someone's life in your hands, and it's a massive responsibility. And I used to think, how could I possibly learn how to be like, how could I possibly live with that responsibility? How do I know I'm good enough for that? And I just say, trust that the training, if you do your training well, you make sure you get your volume of practice, and you look for cases. Like whenever there was a case, even if it was after hours, and if you're going after hours as a training, I would absolutely stay for that case. I'd offer to do the hard cases. I'd want to do those difficult cases. So by the end of it, you've got 5 years of training. That's not a lot of time. Make sure you've done everything you possibly can. And if not, you go to your fellowship year and you plug in the gaps. But, please don't think of it as too much of a lifestyle for that training. Really hit it hard, because at the end of the day, you'll be autonomous, but completely responsible. The buck stops with you. And, that's just professionalism, and I guess just humanity.
Yeah, no, that makes perfect sense.
Mm.
Okay, so still talking about junior doctors here, but more about applications and things. So
Yes.
for junior doctors in states where critical care SRMO positions exist, how important are they in getting on to ANSCA training?
Yeah, so Victoria, I guess, famously has critical care positions, and there's probably almost the same number of critical care positions to anesthetic training jobs. Or it might be slightly more anesthetic training jobs. So it means that critical care is like the audition. It's like the interview. It's where you spend a lot of time, and that's kind of opposite of the Queensland system, where no one really gets any anesthetic time, and they see you pretty much from your CV. And I think these days they don't even count the references. They got a really stringent process where they look at the CVs, they standardize the scoring, everyone gets in the room and scores those CVs, and then they, come for an interview again, which is standardized. And so no one's really got much of a shoe in, or there's no real kind of nepotism going on. But I think not that it's nepotism in Victoria, but if you get that critical care job, it means that you've done your anywhere from 3 to 9 months of anesthetics. And so you're far more employable. Plus, they've seen you, like they've given you the proper interview, which is actually working in the job. And if you're trainable, you're pleasant, you're a good contributor, and you have the capacity to learn, then it's probably far easier to get the job. On the flip side, if you perform really badly, then everyone in the department knows that you weren't a contributor and you weren't doing well, and it'd be very difficult for you to get a job after that failed audition, so to speak.
Yeah, no, that makes sense. It's interesting to hear about Queensland system as well. I didn't realize it was so different.
Yeah, absolutely. Yeah.
Okay, so I just have a question on behalf of women as well. So how doable is it to have kids while training? At least that's the first question.
Yeah. And actually, so the first of all, obviously, I personally have no experience because I didn't have children during training or anything like that. And now that you asked this question, I think it'll be a really great opportunity. We should do a follow-up to this where we'll get one of your mates who helped with the questions. A female colleague of yours, a student of yours, could come in and interview one of my female colleagues who's had kids during training, and maybe even kids after training as a consultant, as a junior consultant. I think that would be a really great, insightful podcast that, I'm sure would be very helpful. So from what I've seen, when I started, it was kind of difficult to have kids during training. It was nothing's officially said, but it feels like it's frowned upon. And I've had colleagues of mine really pioneer this. Like one colleague, she was fantastic. She took it to ANSCA and said, "Hey, why am I paying training fees when I've taken 9 months off to have kids, or whatever time for maternity leave? Why am I paying full fees for training?" And she fought that, and it was. I think again, it's in everyone's best interest to look after our future people. This is women in our industry who are then having children for our future, and we've got to absolutely look after that. So people have pioneered the existing bodies to make it doable. And even likewise, like my department has many really good, female leaders. And I think that really helps as well, because having those leaders, brings their personal experience into making decisions. And it probably is like that in every other disadvantaged setting, where if you get someone in leadership from that disadvantage, whether it's, you know, a medical or chronic illness, or maybe you're an international medical graduate and you're disadvantaged for whatever reason, or you're female, or whatever it is, having people pioneer the way is, I think, really useful. And I think we're going through a nice change in the world where people are really, really looking to see who is disadvantaged and seeing what we can do to help them. So that's the change that I've seen. There's lots of edges where people are still talking a big game but not following through. And I think it's up to a lot of us to try and, you know, push for that more and more, because by its nature, big institutions don't always change quickly, and that's just how it is. But the individuals definitely want change. It's just there seems to be some barriers in some situations to making those changes.
Yeah, of course. So the second sort of follow-up question for that, which you did, I think, touch on a little bit, was just going to be how flexible are ANZCA and the hospitals about this sort of thing? Obviously, you mentioned that you have your wonderful colleague who sort of fought for some more sort of rights there, but I'd still be curious to hear how it's going.
Yes, I don't have too much more of an insight into that. I think they're far more flexible than they used to be. My department is extremely flexible with lots of things. For anyone who has a need, like, you know, they support everyone. So yeah, I'm far more
awesome. It's good to hear. Okay. This one's a bit of a tough one. How do you deal with cases that have unexpected, unfavorable outcomes, you know, permanent disability or death?
So this is going to be one of the most horrific things to happen to any clinician and to their patient, obviously. And I think that, you know, when I reflect on, you know, we have M&Ms every couple of weeks. I've been through many morbidity and mortality meetings where, you know, lots of people will have things occur to them in their career, including myself. And I think the way we get through it is, first of all, we're highly trained, and we come to work, you know, with all of our capacity. You know, we're not unprofessional. We're not having late nights and coming into work in any kind of inebriation state or drug effect. You know, this is not negligence necessarily. It's like, you say you do enough. If you do enough cases in a high stakes world that we play in, the odds are that something could happen, and it could be, you know, regardless of what we do, that, you know, someone might get an infection after we put a needle in somewhere, or, you know, these are the odds, even if we do everything right. I think so. Where it becomes hard is if we make an error in our judgment, or, you know, we just have a mistake from that point of view. And then the first thing is, you know, you will take it really hard. Like, it would be very difficult if you cause that kind of, even if it's, you know, obviously it's going to be unintentional, but even when it happens, there's no way that you're going to feel very good about this. You'll feel terrible, and obviously feel so much empathy for your patient and what they're going through. I think what makes it better is that, first of all, the intention was, you know, you train this hard to have a good career, to try to do your best for the community, whatever that is. And in this case, you're directly dealing with another human's life and the complications that can happen with any procedure. But I think what makes it a bit better is that you just have to accept these things, that something bad happens, it could happen to anyone. And, you know, as long as it's not happening on a too frequent basis, in which case you should really rethink your career. If it's happening at the right proportion, roughly, then this is just part of the nature of, you know, you are paid well and you're trained well to do a good job. And then you also have to deal with the consequences of when things don't go wrong. Beyond that, I think what I've done in the past and what I've seen done is, you know, you support your patient in every way possible. You know, you get them all the referrals and support that they need. So you try your best to make sure they're looked after, but also you make sure that you've openly disclosed to everyone, you know, your department, any kind of risk management, any kind of morbidity and mortality, kind of organizations, to make sure that everyone's trying to figure out a way to make this happen less or never. Like, if you do those things, I think that's pretty much your professional responsibility. And the next thing is to accept that you're going to feel really terrible, do whatever you can to make sure it doesn't happen again. But sometimes, you know, things are just going to happen because we don't know why things happen as well.
Yeah. And just in the interest of sort of transparency to medical students who might be thinking about this, but obviously don't have the direct experience, is it pretty much an expectation that if you go into anesthetics, even doing everything right, this will happen to you at some point?
Yeah, I think in any career, like, even as And I'm trying to think of like the stakes are maybe a bit different. Like I know in surgery, complication rates in surgery are probably maybe 10 times more common, maybe 100 times more common than anesthetics. And that's the nature of, there's far more going on with surgery. There's more variability, there's bigger incisions, there's bigger movements there. Whereas the problems in anesthesia arise anesthesia overall, like in the anesthesia space, direct mortality from anesthesia is probably in the 100 range. Whereas when you look at perioperative mortality, it's more in the 1 in 1,000 to one, 1 in 100, 1 in 10,000 range. So perioperative mortality is more than direct anesthesia mortality. And, our things happen, failed airway. So we train for that, or, severe anaphylaxis, maybe the heart, a patient has a cardiac arrest. So they're very acute things, whereas surgical mortality is more, longitudinal. So yeah, anyway, so I guess what we're saying is that if you do enough of anything, whether you're a GP and you misdiagnose something, or ED physician and something happens, or anesthetics, so there's some level of risk in each of these careers, and you just have to trust the process. Australia is has well trained, you're very 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 well trained doctors, very good colleges that make sure that they credit people the right way, and if you apply yourself through your training and get your practice in and make sure your skills are up, you should be as good as your colleagues. And that's
Mhm.
that's where you can kind of justify that you're doing the right thing.
Yeah, no, that makes sense. Okay, something that's a bit lighter. What's your favorite anesthetic related drug and why?
Yeah. So yeah, it's hard to really say. I think propofol is just a great drug. It's the one drug you absolutely take on transports, for example, because it drops the blood pressure if you need it dropped. It puts someone to sleep if you need them to sleep. It cures, it helps nausea and vomiting. It's just a really flexible medication that does a lot of good. I think everyone just loves propofol. It just has a good feeling. I think that's why everyone wants to go through its Tiva, a good feeling of what propofol does.
Yeah.
Again, all of these drugs are dangerous. It's hard to say you have a favorite drug. That feels a bit weird to say. Um, yeah, it's a really amazing what pharmacy has formulated with this specific medication, but there's not really another medication like it. It's in a class of its own, really.
Yeah. And so on the flip side of that, you have a least favorite anesthetic related drug and why, if
Yeah,
you do have one.
yeah, I love them all. I think there's no one drug does everything well. Like all our drugs are blunt instruments. Propofol gets you asleep and then drops your blood pressure, stops you breathing. Muscle paralytics are really good at that, and they stop you breathing. Opioids are really good at pain, stop you breathing, decrease your heart rate, cause severe bradycardias. So every drug is not a perfect drug. That's probably the biggest problem.
Yeah, no, that makes sense.
But keeps us in a job is the job of anaesthetist is essentially to know the action you want, know the actions you don't want, and then treat the actions you don't want.
Yeah. Okay, have you ever had a case of malignant hypothermia?
No, extremely rare. There's definitely been cases in my hospital that a colleague has had, and I've had people who are malignant susceptible to MH, but never had a case personally.
Yeah, no, I think that's a common. I think most anesthetists probably haven't.
Yeah,
How about neuroleptic malignant syndrome?
yeah, still no. So have not had that either, which is too much anti-dopaminergic agents.
Yeah,
But no, nope, never had that either. We use very small doses in our situation. I suspect that happens more commonly in the psychiatry space.
yeah, that makes sense.
And in the other one, same with serotonin syndrome. I don't think I've ever seen. I think some of our pain specialists, when patients are on lots of serotonergically active medications, in the context of pain management with higher doses, yeah, I think they've seen what could be serotonin syndrome. Yeah.
Yeah, I have heard that serotonin syndrome is exceedingly rare, or at least true serotonin syndrome. Okay, well, given that you work both publicly and privately, so I'm curious about what's better about anesthesia in the public health system versus to private for you as the anaesthetist.
Yeah. So in the public system, you're pretty much in the same, like, especially I work, full time in one hospital chain, which is a number of different sites, but the rooms, the trolley is the same, the machine's the same. My teams are familiar to me over the years. So, I know people, and that familiarity is something that's really important when crises happen. And there's massive backups. So, I've got my colleagues in the room next door, and I know them and I know their skill set. I know, I trust their judgment. Often have a very shared mental model. And then I've got registrars and consultants who are on call after hours. So if a patient has a problem, I can hand it over. I can trust it myself to have a good night's sleep, because I can trust that my colleagues and the system will look after patients really well. Whereas in private, so that's probably the best thing about the health system. And again, from a lifestyle point of view, you get sick leave, you get long service leave, you get sabbatical leave, you get time to do the projects that you want to do. Like, a lot of us will do lots of clinical anesthesia, which is great. But, a lot of the reward of my job is teaching and doing other things to try to make the system better. And I don't think often don't have the space to do that in private. So yeah, I guess, so the next thing, the private health system, I think it's, from an anesthetic point of view, it's far better remunerated. So, that extra money that you make, you can account for with the leave and the long service leave and sick leave. Like, you have to, but even sick leave is hard to cover in a moment. Whereas in public, it's so nice that if you're unwell, you just have to say, look, sorry to call in sick, and someone will be there to cover you. Whereas in private, it's far harder to get covered, even though, sometimes you just have to.
Mm-hmm.
But yeah, so I think in private, the beauty of private as well is it's all you and the surgeon. It's two people who are completely qualified, hopefully at the top of their game in anesthesia and surgery, working with often a familiar team as well for a very specific operation. So the efficiencies that you get in private are just unparalleled. Like, I can do 14 cataract operations, for example, in a morning, and maybe even more, with the fastest surgeons and the fastest teams. Whereas in public, you have 4 or 5, and it's a teaching hospital. You're teaching people. It's a lot slower. So you get pushed to your absolute limit. You get into that flow state, which a lot of people talk about these days, where, you are in the zone, and that morning just goes like this, and you go, that was as good as I could have done that series of anesthetics, because you're doing everything. Even just the other day, I had a Whipple's procedure in pancreatiduodenectomy, and that was in public, but it was just me, my nurse, and then the surgical team, and just having to do everything myself. It felt really good. I was just like, yep, I do this, everything happens. Everything was done in, what was it? It was probably 45 minutes, got all the lines and drips and had the patient asleep. And I was like, yeah, that was me performing at my best.
Yeah, especially after all the training and experience, it's like, cool, I still get this representation to myself that it was all that time and if it was worth it.
Yeah, exactly.
Okay, what's the most nerve-wracking procedure you do?
Yeah, so obviously, that's a really good question, because no matter how qualified you are, I think there's going to be the edges of your comfort zone, but knowing that, you don't extend yourself outside of what you're, qualified to do or able to do. But there's many things that were totally within the scope of your practice, but there's still going to be the edge of your kind of comfort zone. So with anesthetics, by its nature, there's no room for error there's very minimal room for error. When I say that, we give too much, to an elderly patient with not much physiological reserve, the right amount of propofol is good. Too much propofol is a spiraling blood pressure, hypertension, cardiac arrest. If you fail the airway, that's, you've pre-oxygenated the patient, and now you've got, at best 5 minutes in the optimal circumstances before desaturation. So again, there's not much room for error when you're in this anesthetic context. So just imagine the sickest patients, the sickest hearts, ejection fractions of 10% where you have to induce them, and combine that with any other problems. Like maybe they've got a difficult airway as well. Maybe they've got a high BMI. Suddenly there's even less room for error. And I make sure that I've done everything possible. Like I might do an induction, for example, in these tricky patients, and I'm just doing the airway. And normally I do the airway, but I'm also looking at the monitor, set my alarms, manage the hemodynamics. I might have someone just on hemodynamics while I'm just on the airway. I might have 2 people and the nurse on the airway because of how difficult it might be. In some inductions, I might have the pads on because I'm really worried this patient will arrest, and I'll already assign someone to do chest compressions. Worst comes to worst. That's never happened, fortunately. But that's the level of extra kind of, yeah, I go to. So in that same kind of trend, like if I have a regional block that I absolutely need to work, that's also a bit stressful. Like, if you've ever done an awake carotid endarterectomy, patient's awake, you really want that block to work. Or I had a difficult airway, a grade 4 airway in a patient with a shoulder reconstruction, and yeah, this was done I did it as a trainee. I don't think I'd do it this time. I'd probably do an awake fiber optic for this case, but I just said, hey, to my consultant, shall we do this whole operation just with regional anesthesia of the shoulder? He said, yeah, good idea. So we just blocked the shoulder, and the whole time I was just thinking, man, I hope that this block is absolutely perfect and dense and good for the surgery. And it did. It was great, but it's one of those things where you definitely have less room for error. Other things are airway surgery, pediatrics has less room for error. All of these with less room for error, more than the normal narrow therapeutic range of everything we do. That's where I have to be absolutely on the whole time.
Yeah, and I have to imagine with that stuff, it's like, again, you could probably do everything perfectly within what you're supposed to do, and things sometimes just won't work exactly how they're supposed to, because that's the nature of the human body, I suppose. Okay, so in a similar vein, assuming you have an otherwise healthy patient, what's the most daunting surgery to do anesthesia for?
It's interesting because I think that there's no real daunting surgeries anymore. So, in fact, the most daunting surgeries, so the biggest operations are thoracic cases, the liver resection cases. I'm not trained for the transplants. I did that as a trainee, but I don't do it as a consultant. But so, even at the edge of your, like, the most hardcore operations, I think most anesthetists want more of those because we like the experience. So those aren't actually daunting. That most people probably enjoy those cases. And even for me now, in my hospital, we do lots of elective cases, but they're not as sick as, say, in some of the quaternary hospitals that have specialist hemophilia centers or burn centers or trauma centers. So I think in my hospital, we get some super morbidly obese patients. So those are absolutely daunting, but definitely within our skill set. And who else is going to do the anesthetic, right? So the 280, the 300 kilo patient that I had, those are really tricky cases. So any surgery in them is going to be daunting for the patient and for the team. But yeah, we just do a lot of preparation planning and make sure we have lots of things as backups for those cases.
No, that makes sense. Okay. So as far as I understand, the 5th year of anesthetics training is a provisional fellowship year in which trainees can do either like a year of general anesthesia training or like subspec, so like neuroanesthesia, pediatrics, cardiac. What are the benefits and drawbacks of doing a general anesthetic year versus doing a subspec year?
Yeah, it's a good question. So I, surprisingly to myself, I did a very general year, but it's because I was in a subspecialty center. I was in a trauma center, and I felt like I already had a lot of that experience going through training. And so I wanted to do more of the general stuff. I wanted to do more obstetrics, more pediatrics, just more big elective cases, and not the cardiac stuff and the trauma stuff and the burns. And, that I feel like I had lots of experience with that. Also in an extremely tight job market. So I wanted to be in Melbourne instead of, my initial plan was to go off to do cardiac and regional fellowships just to really round myself out as an anesthetist. So I'd almost say, don't worry too much about, potentially think about where you want to work in the future. That's one approach, and then fellow there, because you often get the job at the place you do a provisional fellowship at. Do something different would also be good. So if you've already trained in something, unless you really just love it and want to be the person in that realm, to do something completely different like I did is probably a really, really useful thing as well. And also, generally speaking, people do like to employ someone with expertise in a specific thing. So for employability, either go to the hospital you want to work at, or absolutely train a subspecialty like cardiac, or maybe it might even be systems. Maybe you set up some program, some education thing. Maybe you did cardiac, maybe you did pediatrics, maybe you did some other, liver anesthesia, and that this for the place you want to work at needs that, or you just have a genuine interest in it, and you will find the job you want later on. So I'd say just go wherever your interest lies. Just follow your heart and see what happens.
Yeah, no, I mean, and I like that advice came both from the practical life type of priorities, like where you want to be in things, but also, the science and the interest type side of things as well, because I do think those things need to be balanced.
Mm.
Okay, so one thing I've seen in various videos before, mainly in UK hospitals actually, is that they will have like large scale simulations where you have, potentially 10 or 20 people in a team or something, like doing the treatment for a pretend situation for some particular type of case or emergency or whatever. So do we have those sorts of large scale simulations of those types of critical events and things to retain and gain proficiency?
Yeah, so when I went through training, simulation wasn't as prevalent, but now definitely in my hospital, we've got a massively amazing Center for Education, really great sim team, which I'm part of, and we run lots and lots of training for everyone, nurses, doctors, junior doctors, anesthetic trainees at various levels. So there's lots and lots of training that happens in simulation. But I think as good as that is, it's very time intensive, costly, etc. So I think the real thing is to bridge, have a level of that's doable with the system, but also running lots of drills intraoperatively, and these could be just hypothetical drills as well. But I try to do as many of those with my trainees and nurses as possible. Like you think of the worst case for that, the worst case scenario for your particular case, and just run through what you're going to do, or maybe in a in a relatively straightforward case, just practice a difficult intubation drill where you optimize bag mask and LMA and intubation. So you run through all of those things in a real setting, which is completely safe. And then you get to handle it. Like you can be in theater and say, okay, blood pressure's dropped. What do you do? And you can actually just run through everything that you do without giving the syringe of aramine. You can just go, yep, giving this, and now I can tell you what's going on. You're auscultating the lungs for desaturation, you're taking a pretend blood gas, I'll give you the results. Like there's a lot of things you can do without interfering with the patient and without, giving the wrong drugs to someone, but to run through a scenario.
Yeah, okay. No, that makes sense. So that would be so useful in terms of just, like I said, retaining proficiency and gaining it. I feel like it's so much better to be exposed to these sorts of things in theory before it actually happens.
Yes.
So yeah, it seems like you found a good hybrid between the sort of the extreme cost of big, large scale simulations and the just not doing anything.
Yeah, that's right. There's just kind of the balance of continuously running through scenarios and education, and I think to teach is to relearn. So I think what you really get out of teaching is relearning. It's not encourage anyone if they want to learn something, just teach it, just become the teacher in that.
Yeah, no, I completely agree. Okay, this one's maybe a bit funny, but what's the most difficult concept to grasp as an anesthetic trainee, and why is it acid-base balance?
Yeah, because I think like most of the things in medicine, we actually don't know a lot of what happens. Like we got these models of how things happen, but they're not perfect. For example, you'll have most of the time, propofol works in a certain way, or blood pressure and hemodynamics works in a certain way. And sometimes it just doesn't make sense. And it's because we don't have all the evidence. We only have like cardiac output is invasive monitoring tells you cardiac output, but all we have is heart rates and blood pressure. And we try to interpret situations based on pattern recognition, just like acid base. Like we don't know everything that's going on with with all the relevant things, and it might change. Just like Einstein. There's Newtonian physics versus Einsteinian physics versus quantum. Like in different settings and in different environments, things work different and behave differently. And I think it's not a bad analogy for things like blood pressure, acid base, where we don't know everything that's going on. So it can be hard to find the right model to explain a situation. Like for me, I learned acid base as the Henderson-Hasselbalch equation. That makes a lot of sense to me, and it's held me in good stead. When people started talking about the strong iron difference, I hadn't learned it. I hadn't been examined on it. So it's still hard for me to grasp that concept, though I can see what the patterns are and it makes sense. But it has probably less relevance to me in anesthesia, whereas in ICU or in other settings, you probably really need to think about it more.
Yeah, no, that makes sense. So you'd say maybe one of the more difficult things to grasp is being able to use the various bits of information you have and integrate it to read between the lines and figure out what's going on, kind of.
Yeah, definitely things like for example, propofol TCI modeling. That can be hard to understand as well, because you've got all these different compartments with multiple equilibration constants or transfer constants. So that's difficult. Yeah, definitely any kind of high-end physics understanding flow within vessels. It can be, again, we just model it based on like a Ohm's law kind of method, but that's really not exactly how it goes. It's impedance, it's not resistance, but you've got a pulsatile bed. Yeah, so there's lots of things we model, and I'd say that we just have a good enough understanding to do a good job as an anaesthetist, but not a real physics and chemistry relevant understanding.
Yeah, no, that makes sense.
Mm.
Okay, actually, but so one of the things that I think would be really entertaining as being an anaesthetist, or maybe this applies more to anesthetic nurses, I'm not quite sure. But it's when the patients say things that they otherwise wouldn't say. So, like, how often do patients say hilarious or ridiculous things, like while they're, sedated or being induced or emerging or something?
Yeah, so being induced really rarely, because they're just there breathing with a mask on. I don't generally get people to count down from 10 either. Some people ask to count down from 10. I go, yeah, whatever you want. And they're often sleep really quickly. If someone's sedated, like with something, so they're still talking, even then they kind of just ask stuff. They're just asking questions and finding out what's going on, and what was that noise? No one's really being strange. I think what really happens is on emergence from anesthesia in the recovery, that recovery nurses will have far more hilarious stories. And from my own experience of waking up for anesthesia, I definitely start speaking gibberish. And
Yeah.
I don't want to know what I say, really. But I think in recovery, you'd have far more interesting experiences.
Yeah, maybe I have to befriend a PACU nurse then and ask them.
Exactly. We'll get a pack. Actually, we'll get next one. We'll get a PACU nurse on as well and say, hey, what's the most hilarious things you've heard?
Yeah. I'm sure there's marriage proposals and things, surely.
Yeah, that's right.
Okay, what would you say the coolest procedural skill you have is? So, like, if you have a specific type of block or certain type of access or a maneuver or something like that.
I love regional anesthesia. I feel really proud of my skills in it, because it was very much self-directed learning. I just asked to be in the theater for the cases that are regional cases, and then get all the equipment, get the patient down early, and in the first couple of years I became pretty proficient at any block. So I'm really just happy with with that skill set. So, and especially like some of the things we've had to do, of like doing blocks on people, really difficult patients. I had this one patient who's about 250 kilos, really bad lungs, on CPAP, with failing oxygen levels, pneumonia, but also an ankle fracture, and needed an ORIF. And I remember my boss, who wasn't great with regional, just needed a hand. I was like, hey, do you mind if I have a go at this? And even though he was that large, I managed to find, like, in the popliteal area, no matter how big you are, you still have kind of quite a narrow, there's not too much fat deposition there. So I could still see the nerves, and I could still block them. And the patient was just, it was literally just their lower leg anesthetized for this really emergent case, but their lungs were terrible. So I would have hated to give a general anesthetic for this patient of that weight with that, it's like deteriorated lungs. So yeah, I think regional anesthesia, I'm a real fan of. Definitely, I've had some really excruciatingly risky awake fiber optic cases in patients with failing airways, in front of me. So this would have had to go to some level of surgical airway if I hadn't got it in, because the ENT wasn't around yet. So they, ENT wasn't in the building yet. We had probably 20 minutes before they got in, and I remember just going in with this awake fiber optic and seeing absolutely nothing. It was just pink everywhere. The patient has so much swelling from a C7 fracture. So again, C7 fracture, some level of cervical spine fracture, swelling causing airway compromise. So a real rare kind of system of, a rare progression of problems there. And I just saw what I thought was like an entry hole to something. So I thought, I'm just going to go for that, put the scope in, and boom, it was just that relief of seeing the tracheal rings, and then put the tube in. Everything was fine. And my boss was there. He hadn't done an awake fiber optic in 5 years, so I think he was more relieved than I was. I was extremely relieved, and I thought, this was either overconfidence that I could get it, but I mean, there wasn't any choice. Like, we were the only people there. We had to go ahead and try to do this. Worst comes to worst, if this patient further deteriorated, it would be a surgical airway.
Yeah, which obviously is never ideal. And I have to imagine that the sort of dopamine rush, so to speak, after getting that in would be unparalleled.
Yeah, exactly.
Okay, so in anesthetics, I mean, most medical students probably won't know this, but there's a thing called cannot intubate, cannot oxygenate, which is just what it sounds like. So I just wanted to ask how often you run into those sort of situations.
Yeah, incredibly rare. So often it's abbreviated to CICO, can't intubate, can't oxygenate situation. And it just means that you failed at bag mask ventilation, LMA ventilation, and intubation, which means that there's no other way if this patient to give oxygen. And so what happens is you have to do a surgical airway. So I've never had to do this in my career, fortunately. Would I even say I've come close? I think that case I've just spoken about is probably the closest one in a sense, but it was an awake patient, so I didn't even have to go down the other bag mask element. So it wasn't that close to it. Often there is a podcast previously, if you have a listen, where one of my colleagues had to do two of these in her career. So again, extremely rare, but she had these very unique circumstances. And a lot of my GP anaesthetist mates who in the country, they've had to do it because often it's incredibly late presentation of terrible tumors or terrible infections, and so the patient deteriorates and obstructs right in front of them. So there's no other way but to attempt a surgical airway if the other stuff fails. So yeah, it'd be pretty rare. Often it's in very unique circumstances of pathology rather than a failure of an anesthetic management these days, because there's such good training and education around CICO.
Yeah, no, that makes sense, and I'm really glad that it's rare. Okay, what's the best thing about the people who go into anesthetics?
Yeah, we're just legends. Look,
very humble.
Yeah, very humble. Yeah, I would just say, definitely the people I work with. I've been in the same hospital for 10 years, and I'm so glad that I stumbled across it. I feel like I work every day with people I really, really enjoy working with, and I like and I respect them. But I think, beyond that, I think, you become part of a community, whether it's surgical or any profession at all. And I think the people in anesthetics are, especially from what I've seen at my hospital, they're incredibly caring. I feel like they really go above and beyond. I think they're most very well balanced people. I think they've got the bandwidth just because of the nature of the job that you can have a chat and you can form these good relationships with people. And I think they're well balanced. So they have lots of interest. They're really into being healthy and fit. They love cooking, or they all seem to be foodies and coffee drinkers, and they all have some other nuanced or niche interests, which is often really interesting to learn about. But I think that's lots of doctors, lots of people in general. So I don't know if it's that different, and maybe this is just my sample size that I'm seeing, and I'm impressed by it.
Yeah, no, that's awesome. Okay, and so final question. What's the most rewarding part of the job for you?
Yeah, so definitely what we just said, like working with people that I really enjoy working with. I think if everything else was right, but that wasn't right, I probably wouldn't be working in this field or working in the same hospital or something like that. So I think that's a really big part of it. I think from the patient point of view, I don't think it's a problem at all that I don't get the longitudinal care of a patient. Like, I kind of like the fact that I get there, the patient's super nervous, the surgeon kind of whips in, whips out often, but they're already talked to the patient as well. But I'm there when they're most nervous, and I get to reassure them and give them the confidence that I know I have in myself. I give them that confidence and say, look, we're going to take care of you. It's a great team, and then delivering on it. When a patient when a patient has a specific issue and you say, hey, look, I'm going to sort that out for you, and especially if you can sort it out. Hopefully, if it's something that you really can't fix, you're honest about it and say, look, we're going to do everything we can. But let's say someone is really concerned about pain and you say, look, I've got this, we'll make sure that you are very low risk of any kind of pain, and they wake up and they're really feeling great. I think that's a real win. That feels really good. And yeah, I mean, from my point of view of the career itself, I told you I really liked, now looking back, that we had to go through some really tough training, because I think I want to be part of a high stakes career. Like, I want to be responsible for the things that are really, really important. And in this setting, maybe life and death. I like that responsibility. I think a lot of us do. And if you don't, then that's okay as well. There's other careers out there where you don't need to have that level of stress. There's a level of stress that I think is really good because we can meet that level of performance. And I think, I really like the high stakes nature of the career. And then now, a lot of my life is now building ABCs of Anesthesia and Anesthesia Collective. And just being able to, I think the best part about that now is reaching people around the world and, giving education that's, completely free to people that really need it. And then building that team up to do that. So, a lot of the things we have in the pipeline of people writing articles and doing various animations and videos, I think it's just such a cool thing that people get to do that. And they get to do that with me because I get to learn from them and, we learn together. And yeah, I think that's probably one of the most amazing parts for me about this little journey.
Yeah. And I mean, just speaking about the ABCs of Anesthesia thing, it's like, not only are you doing all the stuff you just listed in terms of, providing education for free, like constantly improving the content and everything, you guys also donate tons of money to help causes that really matter, which is awesome as well.
Yeah, I think we've gone over the 300K mark. I just can't wait to get to that first mil and maybe that first 10 million and just be able to go, you can set up a business and absolutely say, I don't want the money from this business. And I think that's, I'm really proud of that we can do that.
Awesome. That's awesome. Yeah, no, I completely agree.
So, thanks for the interrogation. Look at that. It's almost cathartic to be asked these questions. Like, I don't often speak about these things. So yeah, really thanks for coming up with these questions. And so the next time one of the future episodes, we'll absolutely do a special, women in medicine, children, all the family life stuff. I think that would be really useful for people who are anesthetic inclined who want someone's experience of that.
Yeah, no, I completely agree. I'm keen for it. And thanks for having me on.
So we'll sign off there. Hey, thanks very much especially to you, Luca. Great topic. And yeah, please write into abcsanesthesia@gmail.com if you have anything that you want us to speak about. And maybe you want to interview me about something else in particular, or maybe you want to interview someone else. Like we can have, maybe we can make that happen. So reach out, abcsanesthesia@gmail.com. And yeah, please share this with anyone who might be interested, and we'll see you guys again next time. Thanks a lot. Bye. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.